I think there are many barriers that do prevent psychiatrists from treating addictive disorders. And I think some of the most challenging ones have to do with our own internal conception of what a psychiatrist is. I think that either through our training or through our experience, there is still a struggle within psychiatry to accept that addictions are part of the work that we have to do. Addictions are included in all the DSMs, but for some reason, I think we gloss over those pages. We don't take them seriously, and most importantly, I'm not sure that we fully have accepted that this is part of our professional identity, and that when we see patients, really understanding the addictions that they face and exploring those in detail is absolutely as important as looking at their mood symptoms, their symptoms of psychosis, their symptoms of personality disorder, and all other areas of functioning. Because in so many ways, it's the addictions that will really counter all our attempts to treat those other symptoms or categories of symptoms and diagnoses.
Is that for people who have addiction and concurrent disorders, that the mere sort of point of getting to where it can be identified within themselves, that they have an issue with a substance as well as having a mental health issue and maybe having some interplay between those two, it takes a tremendous amount of internal courage. And I think that means that when we are meeting with patients, they're either working tremendously hard to cover up that they're struggling, and so it feels that we might be asking questions that are uncovering a strength or rather diminishing a strength. So somebody comes with all of their efforts and resources going towards covering up and maintaining function when they're dealing with symptoms and substance. And I think we innately feel that if we're asking about substance, then we're tearing away some of the structure that actually is helping that patient.
That this hasn't been part of anybody's education in any meaningful way, although at least 1 in 10 people will be suffering from some sort of addictive disorder sometime in their life. And those addictions affect why they're coming to a healthcare provider in the first place. So for example, the person who's having difficulty with, say, gastritis may actually be having a problem with alcohol, or somebody who is coming with weight loss and other problems such as that may be using a stimulant like cocaine, or the patient who has chronic obstructive pulmonary disease is actually heavily addicted to cigarettes. So addictions are all around us, but it doesn't figure prominently in the curriculum.
Psychiatrists see patients with, for instance, depression and alcoholism, and they will focus on the depression, feeling once the depression is under control, I will be able to treat the alcoholism, which of course is an error, because the depression is not going to be treated until the alcoholism is treated.
That our system isn't set up for treating either addiction patients themselves or people with concurrent disorders. And what happens is the care will get split. So the psychiatrist will see the mental health aspects and refer even to another hospital to do addiction care when that's not ideal. And that's certainly not ideal from the client's point of view or the client's family.
So I think it's primarily a knowledge problem. I think it's also sort of a role diffusion. Psychiatrists, in trying to provide integrated care, ironically don't integrate addictions well into their daily practice. And you know, it makes sense that they would, because the disorders that they treat, you know, in terms of the underlying biology that goes wrong, the pharmacology, and even using psychotherapeutic techniques, all, you know, the principles that we use to address, identify, diagnose, and treat addictions fall very nicely within our frameworks, as exemplified by the DSM, DSM-5 in its latest iteration. And yet this is something that's not given much time in residency curriculums. It's 5 years, and we have a total combined time of about 2 months that we devote to addictions.
Often patients aren't necessarily forthcoming with that information, and in a busy, chaotic emergency department, it can be challenging to take the time to take a thorough substance use history, especially if the presenting complaint was something else when the patient came in. in terms of treating people with substance use disorders, I think services need to be accessible and available to patients. When there are long wait lists or services are inaccessible, then sometimes those golden opportunities to stop that cycle are lost and patients relapse. So I think people often come to the emergency department looking for support because we are so accessible, and yet moving somebody through those stages of change in one interview can be challenging, and connecting them with the right service at the right time can also be a challenge.
Is that we see patients when they're in the throes of everything falling apart because those resources have not been sufficient to keep things on track. So we sort of see people in the process of losing the function in their life and really in a state of crisis or chaos. And I think so we see, and everything in the middle of those two extremes of the spectrum. And I think the barriers are the chaos and the acknowledging the courage, and also then sort of having to bring a structure and shore up when there's a lot of chaos. And I think that raises enormous anxieties within us as care providers.